We do have a little change in our afternoon schedule, so we have about 10 minutes for questions, and we'll gather again shortly after 1. We can get started at about 10 after 1, and that will still work.
Thanks, Tom. Very interesting. And Mary Brady, I'm with the US FDA in the Center for Devices and Radiological Health. And of course, technology is in my area of expertise, if you will. I'm going to put on both my nursing hat and my regulatory hat here. I heard, and these are more comments than anything, I heard you all alluding to a lot of these things, but I just wanted to kind of get them out a little bit more. The area of obtrusiveness, it really does affect compliance, and it doesn't matter how simple that technology may be. If it is obtrusive in their lifestyle, they may not comply with any type of technology that is in the home. I think age also determines what is obtrusive, and I think Wendy alluded to this as well. If you have a 14-year-old type 1 diabetic, they're not going to walk around with a great big pump hanging off of them. They're going to want something that is less obtrusive, and that will affect their compliance as well. It needs to be incorporated into their lives. They should not have to incorporate that, incorporate into that technology's life, if you will. It needs to be incorporated into their lives. Wendy, you said something about this too, the world of human factors and usability testing. This has to be incorporated from the beginning of inception of technology to the end of technology. It always has to be there, and you always have to be looking at what's going on with the usability of this. Just to mention too, at FDA for home use devices, we do have a guidance for industry and pre-market concerns because there's a lot of technology going into the home that was never designed for the home environment. Home meaning anything outside of a clinical environment where there is not 24/7 clinical care. So we have a guidance called Design Considerations for Devices Intended for the Home Use. And we ask industry to take a look at both the design, the user, and the physical environment in which this device will be used. And something that I continually preach, and you also talked about this, is if it has to be useful and usable or it won't be used. Thank you.
I'm Cindy Kraft, president of the Home Health Section for the American Physical Therapy Association. And I think it was made very clear over yesterday and today the importance of functionality for the patients in home health. And I think the inclusion of these technologies have raised that into the realm of their activities of daily living as well. A great example right now is the use of remote monitoring for telehealth and the issue of taking daily weights. We find many of the nurses in home health agencies that utilize that technology kind of miss the fact that, did you know whether or not the patient can get off that scale by themselves to do that? I've been in the home on those types of visits and seen patients hanging off the door frame, trying to balance themselves on top of that scale to get a weight, which clearly wouldn't be accurate at that point. But I think it's important to recognize that in our changing culture of home health, the role of rehab has to be looked at again. The JIMO decision flipped a switch and put a big light on the issue of patient improvement doesn't define skill. But many of the comments, even here over the last 2 days, seem to relegate rehab services to those patients we believe will improve and aid or support services to those we believe do not. And I think that there is a tremendous opportunity to utilize the therapies in those populations to prevent decline, to keep them out of higher cost care. And we have to really evaluate how pervasive the culture of therapy is in for improvement and improvement only has really reached to the grassroots level in home health organizations, that when you try to talk about maintenance or you even talk about some of the technology that is rehabilitation specific, reminders about activity programs and those kinds of things, and I'm curious for the panel's thoughts on this, I'm meeting with resistance because of the current payment methodology. Many home health agencies do not want to consider technology that would reduce a therapy visit in lieu of this type of ongoing follow-up. So I think that that role and how we look at not over the overall model, but the technology has to be revisited specifically.
Yeah, any comments on that payment methodology and maintenance and replacements of visits that are reimbursed with other efforts that would be convenient for the individual?
I think there is always a concern when we think about telehealth or using technology to bridge the distance that it's going to be used to replace actual visits. And what's important, I think, is to think of this in a more holistic way, rather than saying this visit was replaced and we lost a visit or we added a visit, to think more about making it more effective coordination of services. In the earlier studies in telehealth, people always emphasize this is an add-on, we're not going to replace any visits. Later on, it became clear that if we're not replacing visits, perhaps it's not really cost effective. So there's always that fear. I think we need to think of the whole set of services that need to be delivered with agreed upon outcomes or desirable outcomes, and then figure out which tools can be used to make what more effective. And maybe certain visits may be replaced by virtual visits, if you will, but maybe those then resources can be used towards another aspect of care that can be automated. So it's rather than being a proponent of replacing visits or using technology to automate things, I think we should be thinking about redesigning services and maybe use technology as a tool among many in that process.
I think this is I can't talk to the financing because I'm from a research agency, but I will say that rehab has been a huge area of growth in technology, and and the rehab community has really embraced it because it provides data between visits. It can help you. I'm just thinking of a program we fund at NSF. It's called the WeHab, using the We as a balance board, and so that the physical therapists are thrilled with the ability to use a balance board that's then calibrated in a way they understand, and then being able to get data between visits and have all this information that, and in being able to do something in real time, saying, you know, I see a change here. So I think it's a different model than it's been. It's not replacing, but what it's doing is making, I think it's taking really useful services and augmenting them in a way that helps them be even smarter than they were.
One of the comments I have is that we face this challenge every day in delivery of care. And the way we have tried to overcome that hurdle is by focusing our clinicians, whether they are therapists, nurses, or physicians, on plan of care instead of visits or technology. Because one of the challenges we see is that many a times, though therapy is a great value added proposition to the plan of care, but the therapists are not talking to nurses and vice versa. So there's a nursing plan of care, there's a therapy plan of care, and on top of that, there's a technology plan of care. So there should be one plan of care which all stakeholders should work together, and technology can be part of it. And that is the biggest challenge we face in everyday life.
I think, Peter, you're next. No, I'm sorry, Bruce, you were next.
Hi, Bruce Leff from Johns Hopkins, and I'd like to pick up sort of on the health services research aspect of this. So, Wendy, I'm so glad you brought up the issue of RCTs or not, and maybe you and George could comment. You know, so the notion of designing an RCT to tell you whether something is truly this is better than that. And I'm wondering, you know, I've thought about this a lot. I don't have an answer, but I've always wondered whether RCTs really are a robust method for these kinds of things, these gizmos, because the gizmo doesn't exist in isolation, right? The gizmo is used in the context of people and process and care planning, and it's, you know, implemented in a very specific setting with a payer, with a clinical team, and a very specific social milieu. So I just wonder if you guys have any enlightened thoughts. And, you know, these RCTs take long time. They're very expensive. Right now, Dr. Zanton is studying her capable model in two different ways. One classic NIH trial, where she can't change any of the protocol, and one CMMI Innovation Challenge grant, where there's constant reinvention as you go along. And if you have any thoughts on that, I'd love to hear it.
Thank you. Yeah, I think this is a great challenge. Obviously, RCTs are the gold standard, and we should have RCTs for technology mediated interventions. But I think the challenges you highlighted are key. First of all, the technology itself may become outdated given how long it takes to plan for an RCT and then carry it out. There's problems because things do not happen in a silo. So when you introduce, let's say, access to the internet for a specific educational intervention, you can't prohibit people from browsing other websites. Or when you use a technology, let's say a wearable device for certain things as part of your intervention, there's other usage that this device may have that people may benefit from. There are often deviations to the protocol that are often not allowed that are necessary. One example is in the earlier days when people were using regular phone lines, most clinical trials would dictate for telehome care that you would have something that uses regular phone lines, like the regular video phones. And then more and more people in urban centers started giving up their phone lines to just have cell phones. And then you couldn't possibly exclude people because they didn't have a phone line in their home, but you actually had to because you couldn't change the tool that you were testing, even though you weren't testing a specific vendor or a specific product, but rather this concept of video, you had to be consistent in what you were offering. So I do think clinical trials are important, but there's huge challenges when it comes to technology. So this notion of pragmatic clinical trials or being more flexible in the protocol is something that may be useful in this context, just like we have to be flexible, let's say when we do end-of-life research where waiting for the intervention dosage has to be adjusted to what's going on in people's lives. Similarly, we have to think about technology as something that's not fixed, but rather evolves over time.
I think these are brilliant comments, and I think there's the pragmatic clinical trials are a big focus at NIH now. How do we think about them? We also have been working on different trials that let us pull things apart better, because an RCT says, does it cause X? It doesn't tell you about all the other stuff. So, you know, the fact that RCT, we support lots of RCTs at NIH, but it's not the only thing we should be doing. But there's also trials, there's optimization trials now, there are adaptive trials, and like I said, the continuous evolving trial is one we're really trying to push people to think about. So, you know, there's a whole scale of things we can be thinking about, and with intense data, I think we can shorten up clinical trials. NIH and others are working on ways to improve recruitment. If you know, many of the things with clinical trials, there's plenty of issues, and we all know them. I mean, but I still think, what do I want my mother to get in the long run? I want to know X is going to cause it, you know, that you're going to do this and you'll get this. So can we improve? Yes. Should we have a gold standard? Absolutely. And but this is an area we've been thinking about, but the time to recruit, we can work on that. The time we have to do to get to outcomes, we can work on that. So there's lots of room to improve. It's not just the clinical trial, it's the theory, it's the world it's been embedded in.
Right. Thank you. And Raj, did your CFO care that it was not a clinical trial?
Peter?
Since we're thinking about the future and talking about financing, I wanted to say that I hope we don't create technology silos like we have done with every other component of healthcare. I'm mindful of a patient who recently had a heart attack and was in the hospital, and his remote monitoring device showed that his blood pressure was 82. That information did get to me, but it got to me a day or so after his blood pressure was 82 because of the way the information was routed. Now, he was okay. We made some changes in his medications. I'm thinking about a guy who was laying in bed for 3 days with no food or drink, paraplegic, another paraplegic, who couldn't reach the phone and couldn't afford the $30 a month to pay for one of those things you put on your chest to push if you've fallen and you can't get up. And I'm thinking about having managed 6 or 7 patients while talking to you guys and listening to you guys in the span of the last couple of days. So I know technology can really work. I've had de-identified photographs sent to me. I've sent messages back to nurse practitioners and nurses in the office, guided people's care paths in the last 2 days quite a bit. But I've seen these technologies fail so often because they are developed as a business model by somebody who's going to implant them into a care system according to a structure that's been designed to suit the business model of the people developing the technology, as opposed to thinking about how the technology can be applied to a strategy for a population who need the services. And I know that's part of what Eric was getting to this morning. The vision is out there, but the application is so far behind the vision. You know, we have to figure out a way to put these technologies into a space where they can be applied to the needs of the population.
Thank you. Hi, I'm Kathy Bowles from Penn Nursing and the Visiting Nurse Service of New York Research Center. I wanted to comment about translating the use of telehealth into practice in home care and the need to change incentives within home care for how we track productivity for the clinicians. So if we are ever to use this technology and work it into a plan of care, where some days we do visit remotely using video technology and some days we visit in person, the way a nurse's productivity is counted is often by the visit in person. So the incentive is not there for nurses to use this technology. So I wanted to make the audience aware of that and have you think about that a bit. And also, you know, the fear of clinicians that this technology could replace them. And so a lot of education and to get the buy-in of clinicians to have them use this technology as a tool to help them give better care to patients rather than be fearful of it.
I'll just mention in Department of Veterans Affairs in our home-based primary care program, we have a sort of a financial model in there for VA, and there is an element of 10 visits, and it's not meant to say, oh, well, after 10 visits, then discharge them. It's it was really designed to say people who get 10 visits or more are sort of more complex, and they're a higher cost category. So it's based on that, but we took a move a couple of years ago to say, okay, let's start with this. We're going to say of those 10 qualifying visits, half of them can be telehealth visits. And so, you know, we have some information on that, but what are others doing to sort of integrate that element of our measurement of productivity?
I think that's an excellent point. We are testing different methods of coming up with creative ways of measuring productivity. One example I can give you, which is very simple, but we are testing in certain markets, that if a nurse has 10 patients and patients happen to be of heart failure and they are on telehealth and nurse was making visits as a case manager to those patients and the productivity was based on 24, 30 visits a week, whatever the formula was. So we came up with a method. We said, okay, if you do, how long it takes to manage a patient through telehealth. So it was 15 minutes, including interaction, reviewing the report, et cetera. So we took 4 interactions, converted into 1 productive visit.
Excellent.
And that was so helpful where the nurse or therapist was not feeling threatened.
Right.
Because you don't blame them, you don't want to impact their paycheck, because they're only getting paid per visit in some cases. So coming up with these methods, which are still testing stage, is where we need to go as an organization or as an industry.
And I think to take that a step further, we might think about other things of rewarding clinicians who become more efficient.
Yes.
So we did a randomized clinical trial where we were trying to use the video technology in place of in-person visits. And when a nurse had more spare time because they were efficient using the technology, what happened to them? They got another patient. They got another admission. They got more work. So there was no incentive for them to use the technology. So if they can use the technology and provide better care and get their reward based on their outcomes rather than numbers of visits, that might be a model to think about. Thank you.
Thank you.
Thank you. I think let's all try to be back in our seats by 10 after, a few minutes before if you can, but we'll try to resume at 10 after. Thank you very much.
Thank you.